to disclose. And feel free to jump in, Dr. Botter, and anybody from the panel if you have
Thank you.
So we're going to talk about the importance of screening for substance use disorder, and in addition to co-occurring psychiatric illnesses, as we've discussed previously, that they tend to go hand in hand, and that best practice recommendations state that we want to treat them simultaneously. And so that's why it's important that if we're going to screen for one, we screen for both. I'm also going to just describe a couple very briefly recommended models for assessing and screening. So we're going to cover the ASAM leveling model, and we're also going to cover ASPART today. And then I'm going to introduce you to a couple common screening tools that are public domain and can be used in any primary care and or specialty setting, and sort of just highlight what those are. And then if anybody, you can Google these and get your hands on them. And if you'd like to actually get PDF copies, Rana can send them to you. But they're sort of your standard assessments or screens, sorry, that can be used by anyone. So just to tie things up with some foundation in the epidemiology of substance use disorder, and I know we've already mentioned this in other slides, but it's pretty prolific, right? That we're looking at 136 million Americans above the age of 12 will report being current drinkers. 16.5 million report heavy drinking, which would meet the level of a use disorder. Approximately 24 million will report the use of illicit drug use. And of the illicit drugs, marijuana is the most commonly endorsed. In terms of addiction treatment, there's a little bit of a discrepancy that 23 million, or about 9%, will actually meet criteria to need treatment for a use disorder, but only 2.5 million of those are actually going to receive treatment. So that's a pretty big discrepancy there in our community nationwide, that we have a tremendous amount of folks that need treatment that aren't getting access to it or aren't seeking it. So we know about 1% of US adults will seek specialty treatment annually. So that means that a lot of people are receiving their substance use disorder treatment in non-specialty settings. And we know that some of the issues related to that we covered in that overview lecture have to do with the fact that substance use disorder is still our most stigmatized mental illness. It is fairly costly for institutions or for communities to provide the type of treatment that is recommended for substance use disorder, because it's considered wraparound treatment. It hits multiple domains. It isn't one simple, straightforward intervention. It's numerous interventions applied over time, so it tends to be fairly costly. And then there's just, as treatment providers, stigma within those areas. So there's a lack of interest in even looking into treating this population or getting training to treat this population. And so that translates into a lack of availability. So we know that the majority of people that are going to need substance use disorder treatment are going to show up in a primary care setting because they're going there for other reasons. 82% of adults, 92% of children will see a healthcare professional in a primary care setting at some point within the calendar year. So that equates to about 55% of the 1 billion office visits and 130 million ED visits annually having some form of substance use disorder component to them. So this means that there's tremendous opportunity for those that work in non-specialty settings to reach those with substance use disorders. These are patient populations that may never go to a specialty treatment center, that may not have access to it. And it also captures the sort of the bottom of the pyramid that I'm going to show you in a minute, which are those that have milder use problems. So the people, before they get to the folks that come to see us at ASAP, before they get to that level of problem, will probably show up in a primary care setting or even an ED setting, and could be caught at that stage and have intervention provided to them at that stage to prevent it from getting worse. So that, I think, brings us to why it is so important to have a standard screening and assessment procedure as part of routine care, regardless of which setting you're in, that captures substance use disorder as well as any of the comorbid psychiatric illnesses that come along with it. This helps us to understand who it is that's in front of us, what their needs are, and then match them to the appropriate level of service, hopefully to stop that substance use disorder from escalating and getting worse as time goes by. It also helps us, particularly with screeners, when we put it in routine care, to help us track symptoms over time and adjust treatment accordingly. And that's really important, because if we don't know if patients are getting better or worse, we might not necessarily adjust our intervention. So this is a look at sort of our past and looking at the ways that historically we have approached substance use disorder. So there were two standard models as part of our history that one is called the complications-driven model, and the other one is diagnosis or problem-driven. So complications is essentially, it's not diagnosis-driven, but somebody has a problem. So let's say they have an overdose, they show up to the emergency room, they get immediate intervention, and then they're discharged. They're not seen again until relapse. So there's sort of this cycle that really historically is not that helpful for folks, which is where they don't receive intervention until a major complication is presented. And it's sort of this relapse remittance pattern. And the diagnosis model is very similar. So they have a diagnosis of a substance use disorder, which is driving the problems that they endorse. They might receive a little bit of intervention followed by some aftercare. So this is typical where we see people transitioning from residential or IOP, sort of that standard 48-day rehab model where somebody goes in, gets treatment, they have a little bit of aftercare, and then we consider them to be sort of done. They're off our plate until a relapse, and then they re-enter that system. So both of these models have found to really not fully capture the needs of folks with substance use disorder. Versus where we are trying to move to now as a treating community, which is a client-directed outcome-informed treatment model. So that allows us to really tailor the intervention to the needs of the individual. It also allows us to use some data-driven assessment instruments to pull together all of those areas that are going to be impacted by the substance use or that might be impacting the substance use disorder, to prioritize the person's problems and sort of work in an episode of care model, to have a very clear plan with clear treatment goals to meet each of the domains that are impacted or impacting their use disorder, and then to monitor progress ongoing, because this really is a chronic condition. So rather than waiting for a serious relapse to happen, monitoring as part of their aftercare in an ongoing fashion, just like we would with any other chronic condition like asthma or diabetes or high blood pressure. So that's why it's important to adopt this mindset of using these episodes of care for the long term. And each episode may be more focused in nature. So they're defined by the set of variables to treat either a specific problem, diagnosis, set of conditions, that is then followed by some kind of an aftercare for that episode or a following episode of care. So it's sort of, you think about it as these dominoes of treatment, and each one may have a different level of intensity, may have a different focus, but that way we're sort of always in the process of moving patients forward and up in terms of their functionality. It also speaks to the importance of the need for a continuum of care, because as treating providers, we typically can't meet all of their needs. We're not going to be able to be a one-stop shop in most cases. And so we need to work with all of our community partners, whether that's from their acute inpatient setting all the way down to their community peer support setting, thinking about that is their treatment is really a continuum, and that patients will transition across those stages. So that way there isn't a single service and there isn't a single episode of care that's going to capture all of the needs for the patient. So this shows you a snapshot of where folks will fall in general with use disorder. So the vast majority, and in fact the vast majority they're going to show up to non-specialty settings, are going to fall on this bottom of the pyramid. Like the 78% are really at low risk or they're not using at all. So that's where we're going to just provide positive reinforcement for what they're doing, a health message of some kind, or we're going to do a brief screener to sort of monitor for change continually at those regular interventions. It's really not until we move into this mid-level risky, the 9%, up into the sort of harmful, and then the ones that actually meet criteria for use disorder, that we're going to need to start to increase our level of intensity of treatment for the substance use disorder. So sort of thinking about everybody gets a screen, everybody gets assessed the same way, and then they get categorized. So at the top, you can see under low, risky, harmful, and dependent, you can see a couple instruments, the audit and the DAST, and that's telling you different scores which help you to level which stage a patient is at. So this is the basic foundation of why it's so important to use a screener for everybody that crosses your threshold. One of the assessment models that is endorsed by the state of New Mexico comes from the American Society of Addiction Medicine. It's called the ASAM criteria. There's a lot of trainings available on this if anybody is interested in getting more information about ASAM. It's very user-friendly. It has specific topics or focus areas associated within specific populations and how to assess those specific populations and their needs. And it is recommended by our state as the primary assessment model. So what does it do? It helps us to do that same thing as the pyramid, except a little more complicated, from a little more complicated viewpoint, to essentially be able to stage patients in what they need. So figuring out who they are and what they need. So it gives us a lot of recommendations from screening to diagnosis, which leads to the severity of the condition, as well as their readiness for change. So the stage of change that they're in and what their relapse potential or relapse risk is. And how they get that is by looking at these 6 different dimensions: intoxication and withdrawal, biomedical, emotional and behavioral, treatment acceptance and or resistance, relapse potential, and recovery environment. So looking at all of these 6 dimensions and how they work together, how they interplay together, gives us an idea of the level of care that that patient is going to need. And if we don't match the right level of care, so if we undershoot or we overshoot, we're not going to be very effective, and we might even lose that person to follow up, which is the really poor outcome. So it moves across the continuum. It helps us to level going from acute detox or what somebody needs like urgently, which has a major medical component, to an inpatient level, to a residential level, to an outpatient, and then eventually community level. It also lines up with our CPT codes. So the different types of services that we are able to bill for lines up with how ASAM rates them. It's a very nice and effective model that I highly recommend if you hadn't had training in, that you get some training in, because the data is pretty clear. This is one study that shows how undermatching really worsens no-show to treatment. So if someone comes into my office and I assess them and I give them my standard approach, which is what I offer, but they actually need a much higher level of care, then they're going to continue to remain symptomatic. They're probably not going to return to the care that I'm providing because it's not the right match. It's not what they need right now. And the same would be true if I undermatch. So if I provide them too high a restricted level. So someone really is appropriate for outpatient once a week kind of check-ins, or maybe even once a month check-ins, and I send them to a residential rehab center, that's way too high of a level for what they need. They're probably not likely to go, and they're not likely to trust my recommendation because that's not a good match to what they need. It has also been shown that if we under or overmatch, we're likely to exacerbate dropout, and we're not going to meet our improvement goals as readily. So in conclusion, ASAM is a really nice model. It has good face validity, good reliability and feasibility, and it helps us to essentially be able to predict what level of treatment someone is going to need. ASPART is another model that has been studied pretty significantly within emergency room settings, but can be applied to other outpatient settings. And what it stands for is screening, brief intervention, and referral to treatment. And so what it's doing is standardizing sort of the clinic workflow. So it's a model that helps you, you could still use the ASAM staging model within ASPART, but it recommends a clinic workflow to be able to apply to all the patients that you see. So essentially standardizing the screening tools that you use and the frequency in which you use them, being able to, depending on their score, provide immediate brief intervention for that individual. And then if their score is high enough, being able to level them and get them to the right level of care. So it has a couple essential elements associated with it in terms of that brief intervention piece. So someone walks into my primary care clinic and I give them an audit C or a DAST or both or some other instrument to be able to determine, do they have any kind of a problem? And let's say they pop positive for having some kind of a substance use issue. So then I'm going to provide in that moment some brief intervention, which means going over the results of that screen with them, talking with them about why they're using, what they're using, and kind of getting that information, encouraging them to talk about what they like and they don't like about it. So that's where you're assessing for that ambivalence if it's there. Advising them in clear but very patient-centered terms that this really isn't going to be that helpful for them. Talking about some brief behavior change. So have you considered tracking how much you're using? Have you considered maybe cutting back from, instead of 5 times a day, to 4 times a day? And then establishing a method for follow-up. So being able to say, I'd like to see you again in a week or in a couple of weeks to see how you've been doing with these recommendations. So you can do this in 5 or 10 minutes. It's a very brief, and there's a lot of videos on YouTube if you want to search ASPART role plays. You can see medical providers doing this really nicely. And I've also provided with you a link to an app. So there's an ASPART app, there's an ASPART toolkit that you can download, all kinds of things that make it very helpful to apply this to your setting. In general, what the screener is doing is assessing everyone and telling you what level of intervention they're going to need. So you can determine what that visit is going to look like based on the screen that you provide. Okay, now I'd like to just introduce some recommended screeners, because we've talked about how these models could be useful in your clinical practice. What would be the actual screening piece that you might want to consider if you're not already doing it? Again, the purpose is to target unhealthy or problematic substance use and or mental health conditions to really be able to detect a spectrum, not just a narrow window. A screener is a big broad snapshot. It's not a concentrated assessment where we're looking very focused and detailed. It's really a big picture snapshot. And it also helps us to use some of those models to make sure that we're matching either our intervention that day or the recommendations for intervention ongoing, sort of that continuum of care, where they fall in it. The screener can help us to place them, and that will then improve their overall prognosis. So some of the things that screening can be used for is again to sort of filter those concerns. It should be done either at the beginning of treatment, routinely as part of treatment, and if you haven't seen them in longer than a month, you need to reapply like they're new, getting that screen again. And it can be used in a variety of settings. The screening results should and can be shared with the patient, because they're a big snapshot, and you can use it for that brief intervention within ASPART. It can also help you to track someone's symptoms over time. So just like I know it's routine in a lot of primary care settings to do the PHQ at every encounter. I know that's required by a lot of our regulatory bodies. Well, one of the purposes for that is not just to have one more thing for us to do, it's to help us to track and see if there's any change over the course of treating that person. And if there is, that's a pretty risky change, and we want to be able to intervene quickly. And so substance use should fall in the same category. And it also helps us to be able to make more targeted interventions when we kind of have a better snapshot of what's going on. That's different than assessment. Assessment occurs after screening. And that is really where we're going to gather a lot of information as well as collaborative information to be able to make the conceptualization of what the person's problems are, their diagnosis, and then their recommended treatment plan. And their mental health and substance use are assessed within context of each other. So that's that really thorough H&P psychodiagnostic evaluation, which might have some more targeted screeners or self-report assessments connected with them. But that's really what we're doing when we're doing assessment, which is different than screening. It helps us to really make sure that we're honing in on the diagnosis, we're doing a proper differential, and determine is this person ready for the intervention that we're going to be offering them, as well as what strengths that they're bringing to the table that we want to capitalize on or we want to partner with. And so that really helps us in building that rapport and setting off on the right foot that we have a good treatment relationship. Now, going back to screening, some commonly used screening tools for both adults and adolescents with substance use disorder, and I provided you, again, there are a ton out there. These are the ones that are recommended by numerous bodies, and they're public domain. So you don't have to pay anything for these, unlike some other assessments where you might have to buy a subscription or you might have to purchase a packet, and that's kind of an ongoing thing, which can be a burden to especially community clinics. And I know, you know, a lot of where we work, we don't have a ton of resources to purchase these things. So it's nice that there are some good evidence-based screeners that are freely available. So you can see that these have different either demographics, so either set for adolescents or adults, because they have slightly different presentations, or they're specific to alcohol, general substances, so they have some variability. So I just wanted to expose you a little bit to what they are in case you're not already familiar with them, so that we can start to think, is there something I'm not using I'd like to use, or something that I'm using and that maybe I'd like to use this instead or use it differently. So the CAGE is a very quick and dirty 4 screening question specific to alcohol. And it identifies problematic alcohol use across the spectrum for women and men, for adults. So it's just these 4 questions, yes or no, and it gives us a total, which sort of tells us, are they at risk or not at risk? So it's a really quick and dirty assessment. That's different from the audit, which is the alcohol use disorder identification test, which is the one we typically see used more often than the CAGE. It was developed by the WHO based on the CAGE, but it has a little more sophistication in that it gives us a Likert scale instead of just that yes, no. Now, the only difference between the audit and the audit C is the audit C is the first 3 questions, and the audit is the whole thing. And it tells us, so you can see the audit C are just those first 3 questions. So some clinics like to build the workflow where they give everybody the audit C, and if they're positive on the C, then they have them fill out the whole thing. Or they just, like at ASAP, I know we give them the whole thing, so that way we have it done, and we have a capture on if they're falling into low risk, increased risk, high risk, or possibly meeting use disorder criteria. So this is a nice instrument, and especially since it gives us frequency of use or frequency of problem rather than just yes, no, I have the problem. So a little bit more sophistication. Similarly, the DAST, which comes both in a 10-item and 20-item version, this has an adult and adolescent version associated with it. This is matched with ASAM. So if you administer the DAST, it already levels it for you and tells you based on their score what they are likely to benefit from in terms of level of care. So that if they're outpatient appropriate, or if it's recommended that they're going to need a higher level of care to meet their needs. Because what it's asking is not just use behavior, it's asking questions that have to do with consequences. So it's looking at the types of problems that they're experiencing, regardless of how much they're using. Another nice thing about the DAST is it is fairly sensitive to change over time. So you could do this annually, or you could even do it monthly, depending on how the frequency that you ask them to sort of track, are they improving or are they not improving? NM Assist is one of our more sophisticated instruments. It doesn't stand for New Mexico, it stands for NIDA Modified Alcohol, Smoking, and Substance Involvement Screening Test. And it is actually an interactive tool that combines the ASPART and ASAM models. It is really cool, and you can get it online. You can put it on your tablet. You can have patients take it themselves. You can ask them the questions and input the data. And you can also print out the hard copy. The hard copy is a little harder to navigate because it has some skip features, but it essentially asks you 8 questions that evaluate 10 different substances. So it looks at a range of substances, not just alcohol or opiates. It's like all the substances they might be using. And then depending on their answers, it asks them more detailed questions about each one of those substances, as well as the consequences related to them. And then at the end, it recommends what level of care they would benefit from, and also some resources. So sort of that ASPART stuff, like as the provider, we recommend, some case management. We recommend that they probably have some housing needs. We recommend that that you do a brief intervention with them today in your session. So this is a really nice tool to do, especially with new patients, especially with folks that are not coming in with a substance use disorder or telling you that, because you get a really clear picture of what's going on, and you can identify people that are at risk. So I provided you with the link here where you can get the NM Assist. These last ones you all are probably very familiar with. And I'll let Dr. Bott answer any questions that you might have about these if you're not. But these are symptom trackers. So when someone comes in and tells you that they have a problem, they're not going to necessarily identify the problem, but once you know there's the problem, then you can use them to be able to determine, do they meet criteria? And if so, when and how am I going to administer the medications or the interventions associated with them? So the COWS is for opiate withdrawal, and the CWIT is for alcohol withdrawal. And then the last screener that we use as professionals is, of course, our UDM or UDA. And being able to routinely do this as part of practice, again, like a universal screener for everyone that crosses your threshold, can be very helpful. And it's important to understand the detection times, because depending on how frequently you do this, you might miss if somebody is using and they're not endorsing that they're using. Everything I've shown you up until now is a self-report, so that depends on the patient being pretty honest, that they're forthcoming with their use or not use. And UDA is going to be more objective. So it's going to, as long as it's within that detection time window, it's going to capture use, whether they're wanting to discuss it or not with you. So that's always a helpful thing. And then I provided you a list, but I'm not going to belabor this, of different screening instruments that are also public domain that you could apply for general mental health or mental conditions that are very commonly hand in hand with substance use disorder. So particularly the mood disorders, anxiety, depression, PTSD. And one of the things that I cannot recommend enough that you begin to integrate, if you haven't already, into your regular practice is some quality of life instrument. So there's the WHO Qual is it's developed by the World Health Organization. It's a brief instrument, and it's a really good way of having a conversation with folks, kind of like the UDS, that they're maybe not fully forthcoming with what's going on, or maybe they don't fully trust you to tell you yet, but they might be truthful on this instrument because it's not directly measuring substance use. It's measuring their current quality of life across a range of domains. So their work, their interpersonal world, all of those things. And so at a minimum, when you get that information, you can have a really nice conversation about their treatment goals and what might be getting in the way of why they're a 7 instead of a 10 in this area. That's one to consider if you're not currently using that. And then comprehensive assessments, you all are very familiar with them. How to do those psychosocial evaluations. And then these are some other more comprehensive assessment instruments. Most of these you will have to pay for, except the ASI. The ASI is also public domain in the hard copy. You will have to pay for that if you want the electronic version. But these take all of this information and put it into either a paper clinical interview or an online instrument. And so if you would like some more assistance in being able to do a comprehensive assessment, these instruments do exist. Okay, that's all I have. So if there's any